So I want to talk about four things. I want to talk about the problem we're trying to solve in America today at JumpstartMD: excess weight and associated disease burden. I want to share, for those of you who don't know about it, our health and wellness program, our approach. And then, like Philippe said, I want to share our outcomes on 22,407 patients on a study that we just completed. And lastly, I want to compare those outcomes with those of other commercial weight loss offerings that are published in the medical literature. So, brief disclosure: founder and shareholder at Jumpstart, investor and shareholder at Verta Health. And then a more personal and perhaps meaningful disclosure about my background. As Philippe said, for the decade prior to founding JumpstartMD, I saw thousands and thousands of patients a year as an emergency medicine physician. And what that experience showed me is that the number one cause of death and disease in America, it's not smoking tobacco, it's not gunshot wounds, it's not motor vehicle accidents, it's not physical inactivity, it's not drugs and alcohol. The number one cause of death and disease in America, and by a wide, wide margin, is diet-induced diseases. And you've seen this before, but those diet-induced diseases have been forged by the primary macronutrient change that we made in our diet over the last 50 years. A decrease in consumption of calories from fat, from 40% to around 30%, and an increase in consumption of calories from carbohydrate to replace those fats that we took out. Now you might ask, well, why do we do that? Well, I think you all know this, but after decades and decades of debate, we did that because our government told us to. You can see that embodied here in the USDA food pyramid, released in 1992. And what you can see is that the entire base of the food pyramid is basically carbohydrate. The first level, you've got grains: bread, pasta, rice, cereal. Next level, starchy vegetables, non-starchy vegetables, and fruits. Those are carbohydrates. And you can have up to 20 servings a day. And then at the very top of this tiny, teeny little box with instructions to use it sparingly are fats. So I think it's relevant to know that the USDA food pyramid was formulated primarily by dairy and agricultural interests. I think it's relevant to know that there was not a single physician who sat on the Dietary Guidelines Steering Committee for the USDA food pyramid. And you've seen some semblance of this over the last couple of days. You've probably all seen this before. But these are obesity and diabetes prevalence maps that are put out by the Centers for Disease Control. And I think they illustrate quite well what transpired in the wake of that unprecedented experiment in human nutrition recommendations known as this high-fat or low-fat, high-carbohydrate diet. So before going into that, just a little bit of background. So in 1980, the United States had a stable prevalence of obesity that had existed for decades and decades of around 12%. In 1990, if you would have looked at the obesity prevalence map on the left here, the entire country would have been beige, because there wasn't a single state in the union with a measured obesity prevalence over 14% at that point in time. And so here we are. Oh, by the way, beige is not bad. We'll get there. I'll show you this in a second. But anyways, darker colors in red, higher prevalence, are arguably bad. And they're bad because diabetes and other weight-associated diseases rise in parallel with the rising prevalence of obesity. So here we are in 1994. If you were looking from space, you might say, Houston, we have a problem here. The country's not all beige anymore. Maybe that's the guidelines. 1998, 2002, 2006, 2010, and here we are in 2014. So the 2018 maps aren't out yet, but as you can see, 4 years ago, the country's just literally caught fire. Today, 40% of US adults are obese. Over 70% are overweight or obese. Today, 14.3% of US adults have diabetes, up from 1% in 1961. Today, 38% of US adults have prediabetes. 90% don't know they have it. so that over half, or 52.3% of the US adult population, is currently diabetic or pre-diabetic. And that, as people have been alluding to, is insulin resistance, and that's problematic. So sadly, the future looks even more bleak. In 12 years, it's estimated that 50% of our country will be obese. And as a result, if you're born in this century, you have a 1 out of 3 chance of developing type 2 diabetes. It's 1 out of 2 if you're African American or Hispanic. If you're born in this century, you're the first generation in history predicted to die at a younger age than the prior generation due to diet-induced diseases and despite advances in medical care. For we are eating and now exporting what's arguably the deadliest diet in the history of the world. It's the nutritional equivalent of cigarettes. And it's created this public health disaster that you can see on those obesity prevalence maps. And you can see that here in this article that was published in 2013 in the Journal of the American Medical Association. It's called The State of U.S. Health. Here's a crazy thing. The #1 leading cause of preventable death in the country is what we eat. It's dietary risks. And that estimate there is arguably grossly underestimated, because if you look at the top 5, half of them are diet-induced. So why is it that the modern American diet and associated excess weight are killing people? Well, because excess weight is associated with a host of diseases, not just diabetes, but many more, as you can see here in this slide. Why is it that excess weight leads to decreasing longevity? Because every 5-point increase in body mass index increases your overall mortality by 30%. That's 40% increased risk of vascular diseases like heart attacks and strokes. It's a 60 to 120% increased risk of diabetic kidney and liver disease. It's a 20% increased risk of respiratory disease, and a 10% increased risk of cancer. Now, in our modern age, all those diseases will typically be treated with pills, procedures, outpatient visits, hospitalizations. And I'm not trying to say there's not a place for that. Of course there's a place for that in the 21st century. But what I am saying is that when 75% of our chronic medical conditions could be effectively treated with lifestyle changes, we're over-procedured, we're over-medicated, and yet we're undertreated as a society because we're not getting to the root of the problem. We treat with pills and procedures what could more often than not be prevented, treated preemptively, with forks, with knives, a mountain bike, or its equivalent, through healthy lifestyle changes, ideally inspired by a guide path that looks a lot like this, and that has at its center healthy long-term weight management from the integration of the following 5 elements: meals, scientifically based nutrition guidance, focused on real, fresh, nutrient-dense foods. And as you've seen over the last 2 days, I'm highly biased in this regard, foods that are low in carbohydrate. Movement. Fitness, what C. Everett Koop called the most potent therapeutic intervention in medicine. Mindset. Ultimately, healthy long-term weights and really health is about healthy habits or behaviors. And then there's maintenance. You have to have an equal emphasis not just on weight loss, but on long-term weight management, because what's the point of losing all this weight and improving your quality of life and diminishing your health risks if you can't sustain it? And then lastly, part of the reason we want to have conferences like this, medicine, a scientific basis for everything that you do, everything that you recommend. So that's what we at JumpstartMD call our 5 M's, what our foundation: meals, movement, mindset, medicine, maintenance. In our world, nutrition recommendations are paramount because we very much believe that food can be life-affirming medicine rather than a chronic, silent, and deadly toxin, as it suggests it is in that JAM article. But it's increasingly hard to do that today in a world where obesity and diabetes are really happening to people. And they're happening to people not because they want it to happen to them, but because they're confused. They're confused by this misguided information. They're confused by bad nutrition policy. They're confused by horribly misleading claims from food marketers. And so, as a result, they're not sure what to do. And they're getting obese and diabetic because of accidental ignorance. Now, not saying we have all the answers, but for those of you who don't know about our approach, I wanted to share that. It's what we think of as the prescription to end that confusion. And high level, that looks like this. Eat real nutrient-dense foods, lower in carbohydrate, and thus higher in healthy dietary fats. But individualized, it's been a theme here too, based on people's past medical history, their lab studies, their cravings or proclivity to cravings, their likes, their dislikes, their goals, their body composition, and perhaps one day genetic testing, perhaps one day colonic microbial testing. Now, we're medically supervised, and so we love lifestyle changes. We think that's the source of people's primary success, but we also believe that FDA-approved weight loss medications can complement care for people who are interested, people who are eligible, and that they have a need. We love exercise. We highly recommend it. But we want people to exercise because it helps them feel better, because it helps them function better, because it helps their body composition, because it helps them improve their health. But to focus primarily on food and drink to catalyze and sustain weight loss. Now, in our world, this is what our nutrition pyramid or food pyramid looks like. It doesn't have any processed foods. It has real foods that are dense in nutrients, and by no means can you have 20 servings of carbohydrate a day eating our pyramid. At the base are mixtures of proteins and healthy fats. Moving up, nutrient-dense, non-starchy vegetables. Above that, delicious and liberally consumed mixtures of healthy fats. Nuts, seeds, avocado, olive oil, canola oil, cream, butter. And at the very top, limited amounts of low glycemic, phytonutrient, and antioxidant-rich fruits. Now, on maintenance, our food pyramid changes a little bit to allow a little more flexibility, but based on your individual proclivity to regaining weight or becoming metabolically imbalanced in response to carbohydrate. You basically are going to lose the weight, and then you're going to keep it off roughly the same way with incremental changes. So in our world, we have weekly one-on-one private in-person visits supported by this team of compassionate experts that you see here on the right. In our world, we recommend, again, real, fresh, unprocessed foods. We don't recommend meal replacements. We don't recommend prepackaged foods. We don't recommend weeks on end of liquid shakes because we don't think it helps teach someone how to live and thrive and fish in a real world. As I said before, we want to base everything we do on real science, individualized to each person per their past medical history, their lab studies, their body composition, and their goals. And the beautiful thing about that, and I'll share this in a moment, but that combination of elements delivers real results. And people can do that at any of what is now 13 offices in the Greater Bay Area. In time and soon, we'll expand locally and then eventually further afoot. So I now want to transition to this outcome study. So we've just completed this study. It's on 22,407 patients that we saw in the decade between 2007 and 2017. The data for it was de-identified and analyzed by Stanford-trained, widely published PhD biostatistician Paul Williams, someone that Dr. Krause kindly referred us to, which has been great to work with him. We've never shared this with the public. We're going to present it in 2 weeks at Obesity Week, and then we've summarized the data into 2 articles that we've submitted for publication to 2 journals. So the group's composed 83% of women and 17% of men. The women have an average starting BMI of 31.1, an average age of 52. The men are a little heavier and a little older, average starting BMI of 34.2 and 54 years of age. And here's what you see in terms of weight loss. In the first month, they lose nearly 10 pounds, 9.6 pounds. In the third month, they lose 19.1 or nearly 20 pounds. In the 6 month, 26 pounds. And you can see the blue line's the men and the red line's the woman. And it looks like the men are losing weight more quickly because they are, but it's a little skewed because they started at a heavier weight. If you look at that group or those two groups by percent of weight loss, and I'll show you that in a minute, they lose at equal rates. Now, according to our results, 97% of those losses are coming from a reduction in fat mass. 3% are coming from a reduction in muscle mass. And that's a good goal for weight loss. You want to lose the metabolically dysfunctional fat, and you want to preserve the metabolically beneficial and functional muscle. So here's the same thing, but by reduction in body mass index over time. Patients lose on average 3.1 BMI points in 3 months, 4.3 BMI points in 6 months. And again, that matters for that prior slide because each 5-point reduction in BMI leads to a 30% reduction in overall mortality. Similarly, by percent weight loss over time, our patients are losing basically 5% in the first month, 4.9%. And 5% weight loss is what's defined by the Institute of Medicine as clinically significant weight loss. They allow you a year to do that, however. We do that in a month. At 3 months, they've lost almost 10% of their body weight, 9.5%, and at 6 months, 12.6%. And again, 5% or greater weight loss is clinically significant because it significantly reduces risk of cardiovascular and diabetic disease risk. And as an example, if you sustain 5% weight loss for 2 years, you reduce your risk of developing type 2 diabetes by 57%. So, as a result of that, the FDA has created a threshold for efficacy of a pillar procedure, a weight loss pillar procedure. And that's achieving at least 5% weight loss. So I say 35%. So anyways, at the first month, our patients, 47% of our patients have lost 45% or more of weight loss. In the third month, that's 86.3%. And in the 6th month, 89.7%, or basically 90% of people. Now, Catherine Price, who was here, yes, there you are, she sent me an article last week, which was kind of amusing. We were having this conversation about this. And it was about a recent study that came out in August on lorcaserin, or Belviq, which is this anti-obesity medication. And in this study, the patients who were on Belviq, 39% had lost 5% of weight loss at year 1. And then at 40 months, they lost 8.8 pounds. And the reviewers who were describing this article were hailing this medication as this holy grail, this revolution in weight loss. And I thought, my God. You know, if Jumpstart were a pillar procedure, we'd be making national headlines and hailed as something, I guess, better than a holy grail, whatever that would be. But I guess that's not the world we're living in, at least not quite yet, but hopefully we'll get there someday. Everything I just showed you was an average. These are the averages of different subgroups, and I think it's interesting to see just because it's a little more granular. So in the overweight group, BMI under 30, they only have about 20 pounds to lose typically. And so they'll do that by about month 4, give or take, and then they'll plateau. In the class 1 obese group, BMI 30 to 35, a relatively lower risk group, they only have about 30 pounds to lose or sometimes a little more, and they'll do that by about month 5 or 6, and then they'll plateau. But in the higher risk groups, class 2 obese, BMI 35 to 40, or class 3 obese, BMI over 40, they keep losing through month 9, such that at 9 months, the class 2 obese group has lost 36 pounds or 16% of their body weight, and the class 3 group has lost 46 pounds on average, or 17% of their body weight. Now you can see some of that difference here. This is looking at the consistency and the velocity of losses based on the frequency of your visits. And so we have 2 groups. We have what we call the low frequency group, who attend 50% or less of their visits, and then we have the high frequency group who attend 75% or more of their visits, or a visit every 9 days. The high frequency group is 2/3 of our population at 6 months. Now, in the high frequency group at 6 months, they've lost twice as much weight as the low frequency group. At 12 months, I'm sorry, yeah, that's right. At 12 months, they've lost 2.5 times as much weight. And the interesting thing on the high frequency group is that the duration of losses is longer too. Or said another way, they don't plateau as early. They keep losing, and they keep losing right through month 12. What about medication and the impact of medication? This was a little bit of a surprise to me. We never really looked at data around medication use for us, but we do prescribe FDA-approved medication in some cases. And what we found that the effect was actually relatively modest and relatively short-lived. So in the first month, there's a 6.1% difference in weight loss between the group who are on meds and the group who aren't on meds. Second month, at 4.1%. Third month, it goes to 1.2%. And thereafter, there's no statistically significant difference in the outcomes between the group on meds and the group not on meds. And at this point, I won't speculate as to why that's not a more material impact and how we can maybe change our practice to make that better. But our experience with medication is that, frankly, medication will never be the Holy Grail. You know, you can see that in that last slide on frequency of visits. The people who attend their weekly coaching appointments more frequently, those appointments enhance the commitment to the healthy lifestyle changes that lie at the core of any sustainable weight loss journey. It's not just about meds. So, anyways, those are our outcomes, but the key question is, of course, well, how do they compare with other groups? And I want to show you that, but first I want to just talk about a little bit about weight loss in America. So annually, 42% of Americans are trying to lose weight. 23% report trying to maintain weight. Now, of the group that's trying to lose weight, 80% pursue what's known as a self-directed or self-guided program. They do it themselves. Now, 20% go to a commercial offering, and they do that because commercial offerings in general are 3 times more effective than self-guided programs. Commercial offerings increase your odds of achieving 10% weight loss by 70%. And so Americans spend about $2.5 billion annually on commercial weight loss programs. Now, when they do go to a commercial program, 72% of the time they go to what we think of as the big 3. 45% of the time, they go to a calorie counting, typically group-based program that was formerly known as Weight Watchers and now known as WW. Or WW, I'm not sure. 14% of the time, they'll go to the largest meal replacement program in the country, which is known as Nutrisystems, and then 13% of the time to a prepackaged meal program known as Jenny Craig. And here's how our outcomes compare with those offerings according to the most comprehensive review of comparable weight loss studies, hopefully soon to be ever published in the literature. But at 3 months, as you know, our patients lose about 19.1 pounds, nearly 20 pounds, and nearly 10% of their body weight. Now that's 86% more than Weight Watchers. It's 2 times more than a composite of all calorie counting plans. It's 70% more than Jenny Craig. It's 20% more than Nutrisystems and a composite of all meal replacement programs. It's 2.4 times more than online programs. At 6 months, results like that hold. So we've lost about 26 pounds at 6 months, close to 13% of body weight, 12.6%. Now that's 3 times more than Weight Watchers. That's over 2 times more than all other calorie counting meal programs or meal plans combined. It's 53% more than Jenny Craig, and it's 11% more than both Nutrisystems and a composite of all meal replacement programs. 2.7 times more than online programs. And this is cheating a little bit because it's cherry picking, so not totally fair. But still wanted to share it. If you attend over 75% of your visits, the results are even better, as you know. So it's not just weight, however, that people are losing. You know, at 6 months, that group shows an average reduction of waist circumference of over 5 inches as their dangerous abdominal fat shrinks away, oftentimes enough to reverse a diagnosis of metabolic syndrome, of which waist circumference is one of the criteria. At 6 months, they show an average reduction of blood pressure of over 7 millimeters of mercury, which is similar to the effectiveness of many antihypertensive medications. At 6 months, they show an average reduction of hemoglobin A1C of 0.37, a marker for prediabetes and diabetes. And that's for all comers, whether you're diabetic or pre-diabetic or not. And I know it's not the conventional model, but one can argue that this is medicine. This is medicine that we see every day, improving broad measures of health and with little to no side effects other than improved quality of life. And frankly, that gives me hope, honestly. It gives me hope that the solution to this healthcare crisis is maybe not as complex as the experts would have us believe. Solutions that, for example, embrace the simple concepts that all healing is self-healing, that food can be medicine, that by returning to eating healthy fats, dense in nutrients, real foods, and low carbohydrate foods, and likely less of it, as this insatiable, chronically hungry, always hungry, as David Ludwig said, high carbohydrate mindset recedes. When we do that, we can forge a new path forward that can positively impact the health and well-being of our citizenry. And I know that, I have that hope because we see 10,000 patients a year at JumpstartMD across 13 offices. And so we hear stories like this you see before you here every day of real people achieving real results that positively impacts their real lives. That's what we do. For that, we're incredibly grateful. We find that incredibly gratifying. And I forgot what I was going to say. That's not good. Well, it was really good, I'm sure. Think about that. I know what it is. Thomas Edison was quoted about 100 years ago as saying that the doctor of the future will give no medication, but will interest his patients in the care of the human frame, in diet, and in the cause and prevention of disease. That day in the future is here and now, and it's here and now at a time when diet-induced diseases have raged like a rampant plague across our land. We at JumpstartMD are extremely proud and honored to be part of an effective, a continuously improving, and a preemptive solution to address that root cause, and in so doing, improve the health and well-being of those we touch. So, I won't forget this. With that, I want to thank everyone for attending what's our maiden voyage and hosting a conference, the first ever JumpstartMD Way to the Nation conference in partnership with our friends Doug and Pam. I don't see Pam, but from Carb USA. I want to thank in particular the presenters. It's through your hard work, it's through your dedication, it's through the research that you've done to illuminate the truth that informs so much of what we do to try to serve, to educate, and to improve the lives of our patients. We all hope that you've had a good experience. We've had a great experience at this conference so far. And we hope that we may see you again and again as we build upon this foundation for this initial event with the hope and intent of illuminating the therapeutic efficacy of low carbohydrate lifestyles to improve health and well-being. So with that, I'm happy to take any questions. Thank you again. And I hope to see you in the diplomat room. Trouble.
Don't worry. Don't worry.
I'm running.
Don't worry. I don't have a question. I have a comment.
Oh.
Your final slide, Hippocrates.
Oh.
Let food be thy medicine.
Right.
Hippocrates never met a McDonald's.
Yeah.
So
probably didn't go to the doctor very much either.
I want you to change that final slide.
To say Hippocrates never met a McDonald's?
No. Good food is medicine.
Well, that's perfect.
Bad food needs medicine.
I like it. Can I quote you?
You can, yes.
Outstanding presentation.
Oh, thanks.
We've been waiting for this. I'm Ed Hendricks. I'm a obesity medicine guy from Sacramento. So you've done this for a while. So what about your data on people that are still with you, and what's their maintenance like?
Well, the last time we did a maintenance study, which was about 6 years ago, I'm frankly loath to quote that study, and the data looked so good that I found it hard to believe. And what I've realized over time is that the way our pricing structure back then, people were going to maintenance who were just trying to go at a lower cost point when they really wanted to keep losing weight. So what we showed was, and we only did it to 6 months, but we had a 0.9 pound increase in 6 months, but I think it's skewed data. So this is the data that we have today. Our intent and hope is to hire a research director in January, of which one of the big projects would be, maintenance. That is the holy grail, really. I mean, so to date, I don't have real data to share, and I hope, 2 years from now or 1 year from now or whatever it might be at this conference, maybe we can talk about long-term data.
We look forward to that.
Well, thanks. Ed, by the way, one thing I love about obesity medicine, I want to say this in regards to Ed. I came from emergency medicine, and I probably met Ed at the first conference I ever went to.
So.
And what was amazing about it was this community of doctors who'd found this thing they were passionate about, and they wanted to support up-and-comers. And so Ed is a great example of that. Actually, Steve Finney is an amazing example of that. They're incredibly generous with their time, with their insights. It's not like there's so much in medicine that's kind of hierarchical and stratified and not quite as friendly. But anyway, I thank you. Ed would always send me articles anytime. Ed, I need my help. I need your help on this, and 40 articles that showed up in my email box the next day, and I'm forever appreciative. So, anyways, does that mean I can get off the stage? I'll be extremely happy.